So what I want to show you is a new technique for protecting the endothelial cells during cataract surgery. And in general is reducing the, just a minute, reducing the endothelial cells during anterior segment is a ongoing story since many years, and even with modern phaco techniques, endothelial cells can be harmed during phaco. And the femtosecond laser assisted cataract surgery helps us to reduce the endothelial cell loss to a significant way in many cases. We also learned additional viscoelastic techniques, such as the double shell technique from Ashinov. And still from the 70s till today, different groups are working to find a solution like a soft contact lens material to mechanically protect the endothelium cells. And here are some publications of protecting the corneal endothelial cells with polymacone. Polymacone is also hydrophilic material, and it didn't work really good for that. And also another material called polaxamer, which worked in porcine or rabbit eye, didn't work as a protecting shield for the corneal endothelial cells in humans. So finally, there is a new application of the femtosecond laser, which offers us a great option. Everybody who is doing cataract surgery with the femtosecond laser assistance knows this picture that the femtosecond laser has already done. And when we start the video, normally we all do and remove the capsulotomy or the capsulorhexis. And this is something you should not do. So bring it back. Why? Because it's a fantastic material. It's clear and it's inert and it's fantastic to use it. So don't throw it away anymore. And the technique here in animation shows you, you do the capsulotomy, then you divide the nucleus. And after that, you go inside underneath the capsulotomy and lift it and press it with the viscoelastic against the endothelium. And so it's the own material of the patient which you are using for protect compromised endothelial cells. So we did a little study which is still ongoing. We have now more than 100 patients. We have eyes with Fuchs disease, and especially in these eyes, you should use that. The other eyes were just to see if this technique will work and if the endothelial cells will really tolerate their own capsulotomy on their cells. And the parameters we were focused on were endothelial cell density and the pachymetry, because cornea will swell a little bit during the surgery. Good. There was a study group with endothelial cell protection and a control group. And the control group was always the second eye of the patient. So we did in one patient when we have planned both eyes. We did the one eye with endothelial cell protection with the capsulotomy on the endothelial cells, and one just standard. We looked in this little study, what I can present now is 1 day, 1 week, and 3 weeks. And if we compare pachymetry and endothelial cell densities, we found not a really statistical significance. In columns, it looks like that. Preoperative, naturally, it's the same. On the first postoperative day and also in the first postoperative week, there was no big difference between the protection and without protection. But after 3 weeks, we had, as good as we could measure the endothelial cells, a much better result for the the protection group than without. But you all know it is really, really difficult to measure endothelial cells with the devices we have. So it's not precise enough to really say yes or it works or it works not. The same we had with pachymetry, and also after 3 weeks we saw let's say not a statistical significance, but a clinical significance in a much thinner cornea thickness after the surgery than without protection. And here is just a picture. I finished the surgery, and then you just go with BSS on the endothelium, and then you see on the left side the capsulotomy, which is now removed when the lens is already implanted. And especially in patients with Fuchs disease, it's really amazing how the cornea will look at the end of the surgery. It's crystal clear, and especially the days after the surgery, day 1, day 2, and 3 weeks, we all know that the Fuchs disease is really an enemy for cataract surgery, and often takes weeks that they get better and better and better. But with the endothelial cell density with this Fuchs disease, you have the next day a crystal clear cornea. This is really, this was the most amazing thing. And so the clinical significance with this technique is definitely there, but how can I prove? I cannot really count cells in Fuchs disease. It's with the devices we have, it's not possible. So the only thing is what you have is to prove is clinical significance. And the second part of my talk is, this was now used, the capsulotomy from the same patient in his own eye. But you can also use a capsulotomy from patient A in patient B. So here we see the tinted with the blue capsulotomy in BSS. I aspirate this capsulotomy with just a DMEC cannula. It behaves really very, very similar to a DMEC. It's just smaller. The capsulotomy is 6 millimeters. The DMEC is 8 millimeters. And just let me show here, I hope I can do it. What you can see here, it needs a little bit explanation. This is a artificial iris. And in the center of this artificial iris, there is a IOL clipped in. And this patient was done the surgery 5 to 6 years ago and had now a very, very low cell density, and was referred to us that we have to remove that. And I called the company because I didn't know the device, and they told me what it is. And you see here, 3 parts is an enclavation on remnants of the iris. And this center is an intraocular lens. And what I did is I implanted from the different patient this tinted capsulotomy, put it on the endothelium, and now in a fast mode, I do the exclavation of this implant. Then I have to remove the center part, which is the IOL. Everything is done underneath the protection of the endothelial cells. Then I have to break these 2 parts. And now the patient is aphakic, has no lens inside. And now I have to implant a lens. No capsular bag is there. Therefore, I have chosen the Yamane technique, which I really think is very fascinating. So I do the Yamane technique, and all this manipulation with an endothelial cell density lower than 500 per square millimeters is done under the protection of the anterior capsule with the endothelial cells. And the amazing is, next day it's a clear cornea. And we all know that in these delicate surgeries, it's not so easy to keep the cornea clear, even with visco, because I remove it now. It looks like directly at the end of the surgery, and you have a super, super clear cornea. I have a second case. Now we bring it out. In a second case, this is familiar to many of us. This is a phakic anterior chamber lens, Bykov lens, also 380 cells density, very, very delicate. I have to remove this phakic lens because of the low cell density. I do exactly the same. I bring from a different patient the capsulotomy into the anterior chamber, bring it with visco onto the endothelial cells. Then I remove this anterior phakic lens. And now I also have to do a surgery and the next day. And here you can also see here in this part, the shadow of the haptic of this lens. And when you have delicate cases in the anterior chamber or a low endothelial cell density, then I really would propose to use the capsulotomy of a different patient or of the same patient, whatever you want, and it's great. So to answer the magic 5 questions which Michael just introduced is, what problem does the chosen technology solve? It solves that we have that we can protect few healthy remaining corneal endothelial cells in a significant way. And the innovation solves the problem that I'm using really the unique properties of the anterior lens capsule, and therefore please don't put it immediately away, as we all do it every day, and put it in the trash. No, think about that you can use it, and it is fantastic. And how does this innovation change the life of patients? Clinical, much better postoperative results, and the beauty is no additional costs. And this innovation changed the life of the clinicians, because when you do these delicate surgeries, you can sleep much better after adopting this technique, and has a definitive little learning curve. And why does the innovation excite me? I think it's for the first time that we are respecting and using this precious autologous tissue for the help of our patients without additional costs. So thank you very much for your attention.
Thank you so much, Tobias. It's really, really wonderful techniques to protect endothelium, which is very important for us. I will have a very quick 2 questions. One question is, you introduced with femtosecond laser capsular access. Is it possible, do you recommend also with manual capsular access? Is it possible to use when we do capsular access without femtosecond laser? And second question, when there is a protection endothelium, when you remove capsule back end of operation, is there any complication? Sometimes maybe attachment to the endothelium, maybe you need to, maybe some special surgical maneuvers may be needed. Is it easy to take out? Just 2 quick questions.
Okay. First question, how you create an anterior capsulotomy or a capsular access? It's if you can make it in one piece, then it's good. If it is not one piece, or it is unstable, the flap, then it's more difficult. Definitely it works, but it's much more difficult and much more delicate than to attach it. But you can use it also from the septo, but the septo sucks it immediately away, so you have to look where it is. But you can use it, definitely. But the same thing is, it's the, the longest the learning curve is to change your phaco technique so that the aspiration of the phaco during the protection of the capsule is that you don't go in the direction and aspirate it, that it sticks there. At the end of the removal is you must not touch it. You just go with BSS. You blow a little bit with BSS and it's gone.
Okay.
So to bring it away is super easy. Let's say the most sophisticated thing is to keep it there during whole phacoemulsification and aspiration.
Okay, perfect. So Ashwin, you are doing also amazing surgeries, cataract, cornea surgeries. Do you have any comment and any question?
I think, Tobias, I think this was brilliant. The way that you've shown it and the way that you've described it in detail, it's extremely brilliant. I know till now we've just had viscoat and things like that that kind of protect us, our endothelium in these cases. And it's always an if and but in these cases. Oh, what if that happens? And but should we do this? And a lot of people are also a little bit uncomfortable using viscoat, especially because of the cost that's involved sometimes when it comes to that. And also what happens is viscoat kind of does change, in my cases at least. I'm sure that a lot of people might agree with me. Viscoat doesn't behave the same way as a dispersive would, and so it does change the dynamics, the fluid dynamics of a surgery itself. So having said that, this is a brilliant technique to actually prevent endothelium from actually getting damaged. So thanks a lot, Tobias.